Welcome back to The Explainer. So today we're diving into a really fascinating medical mystery, one that's basically solved by spotting some incredible, super consistent patterns. As we develop, we naturally outgrow certain things. But what happens when a piece of anatomy that was supposed to completely disappear before you were even born just decides to stick around? Well, that's the story of Meckel's diverticulum. It's a condition where this tiny remnant of our embryonic past just hides out in the digestive tract, totally waiting to rewrite a patient's clinical presentation. To really get a handle on this pediatric GI anomaly, here's our roadmap. We're going to look at the anatomy of this fetal relic, a super helpful memorization tool called the Rule of Twos, the complications of bleeding and obstruction, how we diagnose it, surgical treatment, and finally the essential clinical care management.
Okay, let's jump right into Section 1, Anatomy of a Fetal Relic, the omphalomescenteric duct.
To really understand Meckel's diverticulum, we kind of have to travel back to fetal life for a second. During early development, you've got this omphalomescenteric duct. Its job is to connect the yolk sac with the primitive midgut to provide nutrition. Normally, right around the 5th to 7th week of gestation, the placenta takes over and this duct just obliterates. It completely disappears. But sometimes, it doesn't. When that obliteration fails, it leaves behind a remnant. And that is exactly what Meckel's diverticulum is. It pops up on the anti-mesenteric border of the small intestine. And pay close attention to the word true here. It's considered a true diverticulum because the outpouching actually involves all the layers of the intestinal wall, not just some weak spot in the inner lining pushing through.
Moving right along to Section 2, the Rule of Twos, a memorization masterclass.
Now, trying to track down a tiny, rogue piece of tissue hiding inside the small intestine? Yeah, that's a massive challenge. But thankfully, this condition follows a really eerie statistical pattern. It paints this brilliant picture of our patient, famously known as the Rule of Twos. Let's run through these real quick. It occurs in exactly 2% of the population. There's a 2-to-1 male-to-female ratio. Anatomically speaking, it's located within 2 feet of the ileocecal valve. Physically, it's commonly 2 centimeters in diameter and 2 inches in length. It notoriously contains 2 types of ectopic, meaning out-of-place tissue, which are pancreatic and gastric. And finally, symptoms are most common before the age of 2 years. Honestly, if you can just remember the number 2, you've got the core profile of Meckel's diverticulum absolutely nailed down.
All right, Section 3, Bleeding and Obstruction, when symptoms strike. So what actually happens when those 2 inches of rogue tissue start acting up? Well, that's when the clinical manifestations hit, and they usually go one of 2 ways. First up, bleeding. Remember that ectopic gastric tissue? It can literally secrete unbuffered acid straight into the intestine, causing peptic ulceration. This leads to rectal bleeding that is usually completely painless, but visually, very dramatic. It can show up intermittently as tarry stools, or vividly as bright red, currant jelly-like stools. And if that bleeding is bad enough, the child can rapidly descend into life-threatening hypovolemic shock. Now contrast that with obstruction. Because the diverticulum is physically taking up space, the intestine can actually get entangled, which is a volvulus, or a proximal segment can telescope right into a distal segment, known as intussusception. And unlike the painless bleeding, obstructive symptoms are incredibly painful. We're talking intense abdominal distension, nausea, and severe vomiting. And that brings us to a really crucial clinical pearl. Vomiting is not just a passing symptom here, it is a massive diagnostic clue. When you're assessing a pediatric patient, especially right before or after surgery, you absolutely must evaluate that vomiting meticulously. You're looking at the content, the exact amount, and the color. Is there bile? Is there red blood? This is a primary indicator of severe dehydration, and it poses a huge aspiration risk that the care team has to manage immediately.
Which takes us to Section 4, Diagnosing the Diverticulum, the Meckel scan. Since these symptoms can easily mimic stuff like appendicitis, finding the actual source of the problem is notoriously tricky. Standard x-rays and patient history, they just aren't always going to cut it. The absolute best diagnostic test for a bleeding diverticulum is the technetium 99M perpertinate scan, or simply the Meckel scan. The numbers on this are highly reassuring. It boasts an 80% to 90% sensitivity and a really impressive 95% specificity. Basically, a radioactive substance hones right in on that ectopic gastric mucosa and just lights it up for the radiologist. And of course, right alongside this scan, you're running standard labs like a CBC and a basic metabolic panel to rule out other bleeding disorders and check the patient's hydration levels.
Next up, Section 5, Surgical Treatment and Recovery, Medical Management.
Once we've got a diagnosis, the standard treatment for a symptomatic Meckel's diverticulum is just to take it out surgically, but you can't just rush a highly unstable, hemorrhaging 2-year-old straight into the OR. Preoperative interventions require a super strict strategy. Step 1. If the child has suffered severe hemorrhage, their surgical risk is through the roof. The team has to correct that hypovolemic shock immediately with targeted blood replacement and IV fluids. Step 2 is making sure tissue oxygenation is adequate, so we administer oxygen. And Step 3, utilizing preoperative antibiotics to aggressively prevent or control infection. It's only after those fluid and electrolyte imbalances are corrected and abdominal distension is managed that the surgery can actually proceed safely.
And this brilliantly illustrates our final segment, Section 6, Essential Clinical Care Management, Nursing Pro Tips.
The success of this whole ordeal relies entirely on precise, hands-on clinical care. The core nursing guidelines here are absolute. First off, the child has to be kept completely NPO, meaning nothing by mouth. And because of that, the very first therapy initiated is an IV. They also need to be on strict bed rest with frequent vital sign and blood pressure checks to watch out for shock. Crucially, nurses have to record the exact amount of blood lost in the stools, which is often called stool out measure in clinical shorthand. And to prevent any further trauma to an already compromised bowel, there is one golden clinical rule. Absolutely no rectal temperatures or suppositories. Clinically speaking, nothing up but.
Now, when you're giving those necessary IV fluids to a severely dehydrated child, there's a massive hidden danger you've got to watch out for. If you rehydrate the patient way too rapidly with water that doesn't have the right balance of electrolytes, you risk shifting fluids too fast. This can actually stretch out the cells and lead to water intoxication, which is a potentially fatal complication. So that fluid resuscitation has to be exact, measured, and watched like a hawk.
Because those fluid shifts and electrolyte imbalances are such a huge risk during recovery, we have to look for physical signs that the body isn't handling the fluids well. Take a look at the pitting edema grading scale. When water moves out of the vascular space and into the surrounding tissues, you get this swelling. By pressing a finger into the skin, clinicians can grade the depth of that indentation, anywhere from a grade 1 up to a grade 4. It gives us a direct, visual sign of fluid retention and potential renal or cardiac overload.
But to make sure these physical assessments are actually accurate, consistency is absolutely everything. You can't just guess if a kid's abdomen is getting more distended or if their edema is getting worse. You gotta follow strict protocols. First, measure at the exact same time every single day, usually in the morning, right after a fresh diaper or urination and before feed. Second, always have the patient laying completely flat. And third, measure the exact same spot on the body every time. The absolute best practice here is to physically make a mark with a pen right over the umbilicus. That way, every single nurse, on every single shift, is measuring the exact same circumference.
From an omphalomesentéric duct that stubbornly refused to fade away, to life-threatening complications that demand exact surgical and medical precision, Meckel's diverticulum is this powerful reminder of how our developmental history stays with us, and it really leaves us with a provocative question. As remnants of our embryonic past, how many other fetal relics might be hiding in plain sight inside us, just waiting to rewrite a patient's clinical presentation? Keep that curiosity alive, and we'll see you in the next explainer.